thank you to everyone who has joined. Now I'm Christine Mingus. I work at UCLH, and together with Kate Frost from Nottingham, we are hosting this event today. Now, how did this come about? Well, this came about actually following the UK CRF and BRC anniversary conference in Birmingham this year. Now, during the conference, Kate and I and another couple of colleagues from two other trusts in the country held a workshop at the conference. And as I say, post the conference, there was a number of follow-up discussions, and Kate and I were quite keen to keep up the momentum. So we've basically we agreed that we would set up this initial session, and depending on the feedback from the session, there may be future similar sessions to be held. So so this is the first one, focusing on trying to improve the demographics of our trial participants. So Kate is going to go over briefly the housekeeping before we welcome Esther Mukuka from NIHRCC. So Kate, over to you.
Thank you very much, Christine, and good morning to everyone. And thank you so much for giving. I know time is precious, so thank you so much for joining us today. So yeah, I got the boring bit from me, unfortunately, the housekeeping, which could say is the most important bit as well. So firstly, we want you all to be comfortable. You want to feel like this is a safe space for open, honest discussions, constructive discussions. So put your camera on if you feel comfortable, but obviously that is completely voluntary. And we just ask in regards to respecting others that we try and mute when we're not talking, just to prevent any kind of background noise or interference. As I've mentioned, we're recording the presentation part of the session today, but we'll not be recording the discussions. So just for reassurance, we won't be formally recording those, but we are collating feedback via Miro board. So I'm sorry if people felt a little bit spammed with emails before this, but we ask that people sign up to Miro, which is an online platform that we can use to collate feedback today, a bit like Jamboard, if anyone ever used that. So the link is in the chat, and one of my colleagues, Sean, is going to be putting that in the chat as we go along. So if you haven't already signed up, please do sign up, and that'll just enable everyone to give feedback at the same time during the breakout rooms. If you have any questions while we are presenting, please do put them in the chat or raise your hand at the end of each presentation. We are quite strict on time today, so if we don't have the opportunity to get around everyone who raises their hand, please put your question in the chat and we'll make sure that that is answered for you. Please switch off phone, avoid checking emails. Like, what we really want today is that engagement, those constructive conversations. So we please ask that, just engage and enjoy, I think is the, probably should have been top of the housekeeping there. And just in those breakout rooms, we just ask that, we be kind to each other, we respect each other's views. And we really see this as an opportunity for us to come together across our NIHR infrastructures and collatively try and think about what improvements, what support, share best practice around the collection of research participation demographics today. And what we are hoping is that the feedback we receive will be fed back up to the NIHR Coordinating Centre as well, which I'm sure Esther will mention during her presentation. So that is the housekeeping. That is the housekeeping. So,
Okay.
yeah, I'll stop sharing and reshare. So, next on the agenda, we have our introduction and setting the theme from Esther. So, are you there? Esther is the NIHR Director of Research.
I am here.
Yay! Would you like me to share your slides, Esther?
I will control them if that's okay.
Absolutely fine.
Yeah, it just helps me. That's if I can let me make sure I can find it. But I think it's easier for me to work through them. I cannot find. Oh yeah, there we go. There it is. If you could just let me know if you can see my slides. I'm mindful that I haven't got enough time today to talk through all of the slides, so I will do my best. Hello, everyone. I am Esther Makuka, an NIHR Director of Research Inclusion, and it is a privilege to have some time with you today to talk to you about, or set the scene rather, on why it's important to collect demographic information. Today in particular, I'll focus on participants' data, because I think that's your focus for today. But let me start off by setting the scene and just reminding everyone of NIHR's mission. Our mission is to reduce health and social care inequalities and improve the health and the wealth of nation. And I like to say that behind all of that is actually knowing who we serve and understanding what we need to do through data to provide a needs-based approach to care and a person-centered approach to care as well. So sitting behind that is the NIHR's research inclusion strategy. Some of you would have seen this strategy, the 5 themes, in different format, but these are the underpinning themes for the NIHR research inclusion strategy. And for our discussions today, theme 4, which is embedding evidence-led diversity and inclusion approach, is the most relevant. And we've been doing a lot of work in this space. So let me just set the scene as to why participants. Let me set the scene quickly as to why participants' data is important. This will not be new for some of you, but it's for us at the NIHR and the Coordinators Center. I'm really sorry. Can everyone? Yeah, thank you. Yeah. So why participants' data is important? First of all, it's assessing the safety and effectiveness of treatment. For participants' data in particular, the reason why we are pushing on this, and I'll give examples of how we're pushing to collect better participants' data, we need to ensure that the treatments are safe and effective for the different demographics. There are many examples of where clinical trials and the exclusion criteria have removed certain groups for sometimes relevant reasons, but what it means is that the therapies and treatments that emerge as a result of the clinical trials are not effective for everyone or the majority of people that experience a particular or have a disease burden in a particular area. Ensuring fair and reliable results, improving patient care. This is one of our missions. As you know, NIHR has a huge strategic focus on patient safety, patient care, patient and public involvement, and collecting demographic information is important. Knowing the person behind the healthcare need is important, and then understanding different patient populations. So for the first time in 2022, the NIHR collected or tried to analyze the data available on randomized controlled trials participants, and that's available on our website. And while it isn't perfect, it's a good start, and that's highlighting for us why we have a strategic need and strategic ambition to collect this data. But it paints a picture as well, but also sets the position for the future. Another option we have through the NIHR, and this is through the Research Delivery Network, is the demographic profile of participants through the PRES survey. Now, it is not the most robust, but it is, in addition to some of the work we're doing, which I'll talk about later, it is the only measure of diversity we have for research participants. And while this is not good enough and it is not fully representative, it is a proxy for us. I've put some data there, which I'm not going to speak to because of time, but this is an example of how the NIHR is pursuing its collection of diversity data. Moving forward, we have started working with NHS England and our colleagues there to ensure that we can collect better participants' data through the Edge Pilot project. Some of you would have seen the Edge Pilot project in your trust if you are based in trust. And what we are aiming to do is collect, analyze, and aggregate information about sex, age, location, and deprivation decile of people taking part in NIHR-funded health research. Now, phase one is quite limited, and again, we understand that not every trust uses Edge, and there are other LPMS systems. However, this is a pilot project in order that we can understand what needs to be done to improve the collection of data. So again, I have listed on here some of the reasons why it's essential for us to have this data. And actually, this project, I should say, while in partnership with NIHR, it is led by the Department of Health and Social Care. We are looking, it is open, sign up and uptake to join the pilot is open all year round. And we're looking to get people to get the NHS Trust to take part in it. There will be a phase 2 of the project and probably a phase 3 to collect disability data as well. But this is an example of some of the work we're doing at the strategic level to collect data. So this is how the pilot is working. Research delivery staff will put participants' NHS number into Edge. Edge collects the NHS number from trusts who have opted in, and this is why we're pushing for trusts to opt in so that we can get the data, and that data is then sent to NHS England. NHS England matches the data we have to NHS number and to the specific demographic information we're looking for, and then the RDN uses this data to create a visual dashboard. We on the research inclusion team will also do some analysis of this data. So I've got a slide here on how the data will be used. We will be aggregating the data. We will be ensuring that we are that the data remains anonymous, but we want to use the data to monitor gender balance. We want to use it to compare recruitment rates in rural and urban areas, in coastal regions as well, to ensure that actually we are delivering the right research in the right settings. And some of you will be familiar with some of that work. Here is just a picture of what the pilot phase looks like, which is we're collecting age, sex, and socioeconomic status in the first phase. And then the future phases will look to collect ethnicity data. That will be phase 2. Phase 3 will focus on disability, because it's important that we collect that data. But just to stress that disability data is currently not held within NHS record system, but we are exploring how we get this data with NHS England colleagues, and we meet regularly with our colleagues over there to come up with the ideas needed to push that work forward. So I'm going to just talk about some of the other work we are doing in the NIHR that Christine and Kate suggested I talk about. Some of you would have heard that the NIHR made inclusion a condition of funding in November 2024. And that work in particular really focuses on the ambition we have to ensure that research inclusion is embedded from design all the way to dissemination and knowledge mobilization. So that's the first phase of our work. It really addresses inequalities in the design of research, because for us, if we're not addressing some of the gaps in the design of research, then we will always be stuck taking corrective action, because inclusion has not been thought about from the conception phase of research. So there's more on our website and more information, but I'm happy to take questions about that. The next phase of work, as you can see, this slide just shows what we mean by inclusive design, and that's from initial idea all the way to impact. And I should just state really quickly that what we are asking researchers to do here is to cost for research inclusion. It's important we see the cost associated with research inclusion. So that's phase 1. Phase 2 of the work we're doing is sex and gender. You would have seen, or some of you may have seen, that we've launched our first ever sex and gender policy that was launched on this Monday. So Monday just gone, the 10th of November. And we provide policy and guidance and support to researchers on how to effectively collect and effectively disaggregate sex and gender data. Now, that forms part of inclusive design of research and forms part of our inclusion as a condition of funding. I'm happy to provide slides and links to that. And just to say also, in the summer, we worked with the chief medical officer to come up with an agreement across the sector and with charities to ensure that all the people are also considered and factored into the design of research. All of this information is available on our website. You can see it, and I'm happy to take questions, but I am conscious of my time, so I'm going to stop here. Thank you.
Excellent. Thank you ever so much, Esther. Yeah. So we've allowed a couple of minutes for questions. I see there are 2 or 3 questions in the chat. Shall we take questions first of all, Kate and Esther, from the floor, but rest assured, if we don't have time to answer all the questions in the timelines, we will follow up every single question that's been added to the chat. And if you haven't had the time to add them to the chat or put your hand up, then please do. So yeah. Shall we deal actually with the questions in the chat first? Actually, that might be better. Right. Should we start with the first? Yeah. Sorry, Esther. Sorry.
Yeah, no. So I can see the questions in the chat.
Okay.
The first question is around the confusion around sex and gender.
That's it, yeah.
Yes, that has been flagged with DHSC, and we know that there are issues. In fact, if you see from our RCT report as well, we have already flagged that there's a lot of confusion out there on what is sex and what is gender. And our aim with our sex and gender policy is to ensure that there's clarity to researchers about what we mean by sex and what we mean by gender. But yes, it has been flagged, and that means that our pilot phase will be heavily caveated for those reasons, because there is still confusion out there in the system. But yes, thank you for that question. Okay. The other question is from Karen. I apologize if I get people's names wrong. Hello, I've got a question in Edge. Yeah, we're currently using our patient's local hospital number, and how would this be collated if we're not using NHS number? So, Karen, thank you. To be honest, I don't know that if you're using a hospital number that we would be able to include that in the current NHS pilot, but I'm sure that our NHS England colleagues and DHS colleagues are aware of this, but I would also flag this. But I would, because our focus is on Edge and linking Edge, what's in Edge, to the NHS number, I think if you're not using anything, if you're using anything other than the NHS number, it would not be collected in the pilot phase. So there will be a lot of data that is missing in pilot phase, but we are learning, and there will be continuous improvement with the project.
Okay, I think we're time just for one more quick question, then we'll have to move on to Kate's presentation. Thank you.
So yeah, there's a good question here from Sean Leo. Can you give some examples of how a researcher could cost inclusion? The simple answer to this is there is a whole toolkit we have for costing for inclusion that has examples for how you cost for inclusion. But a quick example would be, access to specific databases. So someone costed for access to Biobank, which is about £9,000. But in order to do that, that access was fundamental to get the samples required from a variety of people, and to ensure that the design of their research was inclusive. Now, I don't know the decision that was made, because that's made at the committee level, but that was an example. I'm still waiting for a decision from that, but that's an example of how to cost for inclusion. Another example could be working and paying people who support the design of your research. So, for example, paying patients and paying volunteers that support you with your work. That could be another example. But we have a whole toolkit, and your research support service are well informed to help you with the design of your research and with the costing, with the inclusion costs that need to go into your application. So please reach out to your research support service.
Thank you, Esther.
That
was a brilliant introduction, and clearly there's a lot of questions are particularly around the subject of the pilot. So hopefully you'll be able to follow up with Kate and I some of the questions that have not been able to be addressed. But just because we're running a couple of minutes over, I'm going to move on to Kate now. She's going to talk about some work that's been done at Nottingham. So Kate, over to you.
And Esther, are you okay to hang around for a little bit, because we have some amazing questions in the chat. So if you're able to respond to them now, that would be amazing.
Oh, that would be good. Yeah.
Your time is very precious.
I'm hanging about, and I'm just on my website, and I will try as much as I can to give links and to answer. Thank you.
Excellent. Oh, thank you so much, Esther. That was absolutely brilliant. So informative. And yeah, we have had a lot of amazing questions in the chat. So hopefully that will encourage some conversations in our breakout rooms as well. So I'm just trying to get that full screen. So can people see my slides? Give me a nod.
Yes,
excellent. So I'm running a few minutes behind, so I'll try and whiz through this example. As Christine mentioned, we presented some of the pilot projects that we have both done respectively within our organisations. So we just wanted to give you an example and kind of set the scene of what may already be happening. And I understand many of you may have your own projects that you'd like to share during the breakout room. So the project we did at NUH was really to try and understand, like we know, as Esther has very poignantly highlighted, there is an issue with unbalanced representation that can then lead to the widening health inequality gap. So we knew we needed to identify, to improve, we need to have a baseline. We need to understand who are our participants in research at NUH, and what are their demographics, to then actually instigate improvement projects to make sure that we are being inclusive and representative of our patient population. So we had that question. We knew we needed a baseline, but what do we do from here? How do we do that? So what we wanted to do was compare our research participant community with our Nottinghamshire and our hospital population to make sure that they were representative. So after quite a large scoping exercise, what we found is that we actually have an incredible team at NUH, the data analytics team, who of course have access to all of this data. They have all the data for NUH hospital participants, both inpatient and outpatient. And what we also have at NUH is on people's electronic medical records. When they are part of a research study, they should be highlighted, flagged on the medical records as part of a clinical trial. So we do have that benefit, although there are limitations to that, which I will mention. So we work with the data analytics team, and they very kindly pulled this data for us from the calendar year, from Jan 24 to Jan 2025. So that calendar year, the NUH patient demographics, as well as the research participant demographics. So we could try and identify any gaps. We received a fantastic report that was hugely insightful, and I'll just go through some of the outcomes now, but it does mean now that we have that report as a baseline that we can start to use on a monthly basis, that can then be added to our reporting metrics as part of all of our infrastructures at NUH. So what did we find? Generally, we found that age profile matched almost. So the researchers in dark blue, NUH patients. So we're a bit lower across the board, but then in some instances, for example, in research, we're recruiting a much higher percentage of trial participants in the children's and young people theme than anywhere else. And obviously you can see here, male and female, there were no huge disparities, although it looks like we are recruiting slightly less female participants to attendees at the hospital. The key element was when we got to ethnicity of research participants. As you can see, there is a huge unknown, an absolutely huge unknown in regards to demographics, which is a massive limitation that was identified. But as well as that, it looks like we are recruiting a lot less in regards to our Black ethnicity at NUH to who is actually attending in the hospitals. So I'm happy to share like the full report. We also have a poster presentation we've submitted, and this is really a baseline for us now to understand what we need to make improvements on. So we know we need to focus on Black ethnicities and research improvement at NUH, but also we're working with NUH to identify the missing demographic data, because there's a huge gap in demographic data actually being reported in our electronic medical records. So we are working with clinical teams to try and do a campaign around understanding why this data is so important and why we need to collect it, because there are, you know, there's a massive gap in collecting that data. So I will stop there. So I think I went a minute over. And pass over to Christine to present your.
Yeah, thank you. Oh, excuse me.
Let me just stop sharing.
Bear with me.
Any questions about that, please pop it in the chat, and I'm happy to answer in the chat. And of course, if anyone wants a separate conversation, then please let me know.
Okay, I'm just trying to put it onto into the mode for the full screen. Oh, that's it. Yeah. I can't actually see. I can't actually see anybody's face at the moment. So, but can you see the full screen? Sharing. Okay, that's fine. Okay, yeah. Welcome again, everyone. Yeah, my name's Christine Mingus, PPIE Comms Lead for UCLH Clinical Research Facility. Now, in the next 5 minutes, I'm going to give you a very, very brief overview of a pilot exercise that I carried out over 6 months at the CRF, and the aim of this was really to try and improve the completeness of the ethnicity data that we have for our participants at the CRF. So how did I go about this? Well, last year I put together a flyer, which you can see it here, which could be used as like an aid or a tool particularly by the clinical staff when they've got the participants in front of them. So I put this together with the aid of and the input from other people, including public contributors from our UCLH Patients Experience team, from the head of PPI at the UCLH, etc. And yeah, so this was the final result. And so this was used by clinical staff when they had participants in front of them, and if they noticed that the ethnicity was missing from the electronic patient records, then I was encouraging them to explain to the participants why it was important. We have this data, and encourage them to ask, would you mind, sharing your which ethnicity, you sort of closely relate to, or if patients preferred, they can take this flyer home and update it themselves on UCH My Care. Alongside the flyer, I give regular updates at our what they call capacity meetings, whereby I'm just reminding all staff about the importance of collecting this data. The pilot ran from December to May. So this is a top line review. Okay, what were the main figures? In the interest of time, I'm just going to focus on the column saying data captured, which means data ethnicity data captured. So this was for all the CRF studies, the ones that we fully support and partially support. I was pleased that the percentage of ethnicity recorded did go up, and the amount of data not captured went down. Now I then thought, well, is there any difference between the early phase cancer trials and neuro trials, which are our two main areas that we support? first of all, looking at the early phase cancer trials, they already started at quite a high baseline. Surprisingly, there's actually a slight decrease in data captured for them. I'm not quite sure why, but interestingly, when we looked at the neuro studies, which started at a much lower baseline of only 31% of participants on average before the pilot, we had data for, but the average over the 6 months post using the flyer went up to 41%, so that was quite encouraging, and the data not captured has gone down. So finally, conclusions, next steps. I mean, I think this pilot produced some modest improvements, definitely. It looked like it's a bit harder to improve the data captured for the early phase cancer trials, maybe because they're already at a high level. The neuro trials obviously need a more continued, perhaps more targeted approach. I'm still to this day reminding staff when I go to their what they call capacity meetings about the importance of this. And finally, a few of us put our heads together here at the CRF. We've decided to put a new registration form together. When patients registered at the CRF previously, they just used to write on a piece of paper their next of kin, which wasn't maybe the most professional, but now we have this new, more professional form, which also includes some demographic data. So this is now being used. It's been used since September, and I'll be reviewing the data in March, give it a 6-month period. And then I hope to share the results, across UCH teams, departments, and of course other colleagues around the country from the UK CRF network. So that's, I'm just going to stop sharing there because we're a wee bit over. Yeah, I think just in the interest of time, and because we were planning on having the breakouts from 11 till 11:30, I think for if you wouldn't mind, if you have any questions for me, if you can add into the chat, or you can always email me. Apologies, we haven't really got time to take questions now. Perhaps at the very end there might be questions, but we're very keen for everyone to have a chance to discuss discuss the 3 questions that we have in their breakout room. So Kate, can I hand over to you again, because I know you're going to discuss the breakout rooms. Kate, Kate, you're still on mute. You're on mute. Oh, Kate, yeah.
Oh, can you hear me?
Yeah, yeah.
Oh God, thank God. It stopped. Yeah. It stopped working for a second. Okay, no problem. So we are now going to split into breakout rooms. I do apologise that today has seemed a little bit rushed this morning. We were quite ambitious, so we fully appreciate that. Hopefully when we have a follow-on, we can make more time for discussions following presentations. So I will be shortly putting you into breakout rooms, and we will have half an hour in there. There'll be roughly 6 per breakout room, 6 of you, which will hopefully enable some really good, rich conversations. And as you can see, we are asking that you use Miro board, which Sean is kindly demonstrating on the screen. If you haven't already created an account, Sean has put the link in the chat again. But Sean, do you just want to quickly go over how to use it in a nutshell, if that's okay?
Yes, I'm hoping it's relatively intuitive. So we have our 3 questions that you'll be asked in your breakout room here. And all we're asking you to do is pop on post-its with your thoughts onto the appropriate question. You will see that there is a broad range of post-its just to the left of the questions. You can also go onto this toolbar and find your own sticky note, add your thoughts. Hello. And make it a more reasonable size. So that's all we're asking you to do today, is just add your thoughts. I will be on the Miro board rearranging them into broad themes. And also, if there are any issues with the Miro board, feel free to either message in the chat here or message me directly, and I will help you out. Thank you so much, everyone.
Thank you so much, Sean. So we've got 3 questions that we would like you to answer. And what I'll do is I'll put those in the chat, and we'll also be sending announcements, so trying to kind of manage when to move on to the next question. These are the 3 questions here. And they're also on the Miro board sticky notes as well to prompt you. So without further ado then, enjoy. I'm going to split you off into the rooms. You should get a notification shortly. This is just done automatically, by the way. So it's no, me and Christine have got no influence on who gets put into what rooms. So hopefully it'll be nice. You'll meet some new people. And yeah, please enjoy your discussions. We'll be updating you. And yeah, please don't hesitate to message in the chat if you have any issues at all. So I'm just going to open the rooms. So it should notify you that you should be pulled into a room and you'll be sucked away into that room. Is it? Yeah, oh, I can see it's working. Okay. See you soon, everyone.